Dr. Yeager, what eye-related symptoms do you typically see in pediatric NF patients? When should families seek evaluation?
The symptoms and findings in the eye from NF are really wide-ranging, and they impact all parts of the eye. Some of these findings cause no symptoms at all, and others lead to significant symptoms, including decreased vision. And so if we think about how the eyes are impacted, we can think about the eyes from the outside in. So starting with the eyelids, you can get neurofibromas or growths that occur in the eyelid area. And these can get big and bulky, and they're usually on the upper eyelid. They can cause what we call ptosis, or the eyelid gets droopy, and that can block the vision. And so you'll see a droopy eyelid and a thickened eyelid. And you have to worry about also when it blocks the vision. If you go inside the eye, if you look at the colored part of the eye or the iris, we talk about Lisch nodules. These are growths that occur on the iris. They are not dangerous, they are not cancer, but they're very characteristic of neurofibromatosis, and they oftentimes help us diagnose the disease. When these do not cause problems, they do not cause symptoms typically. If we move back into the eye, you have a lens in the eye that's clear. You can get a cataract, but that's more common in NF2. But cataracts cause blurry vision and decreased vision, but they're treatable. So you can remove a cataract with the surgery. If you go further back in the eye to the film in the camera, that's the retina, you can get some benign growths back there that are usually not causing issues. And then if you go all the way back and look at the optic nerve, that's the nerve that connects the eye to the brain. It's like the electrical wires for the eye and the brain. You can develop what's called an optic nerve glioma. And these develop typically in early childhood. They can present with eye bulging, or what we call proptosis, where the eye looks like it's displaced forward or downward or in some way. You can get strabismus or eye crossing or misaligned eyes. You can also have decreased vision. Some of these patients are, in general, with NF, are at risk for glaucoma. And in small children, that can be symptomatic, like eye tearing or a hazy looking eye, or the eye starts to get enlarged. And these children in general are at risk of strabismus, so eye misalignment. When do we examine children, you ask? Well, it's important to examine children as part of the workup for neurofibromatosis, right? I mentioned some of those characteristic lesions like Lisch nodules. We can take some photographs, types of photographs that allow us to look for lesions, and this helps with diagnosis of NF. So we see a patient as soon as the question of NF arises, a patient will present to the ophthalmologist, and that's where our relationship begins. We then follow patients once they do have a diagnosis throughout their life, and this is at regular intervals and usually at least annually, but we work together as a team depending on what we see to decide how often it would be. And it's important to realize that things can come up with the eye over time. So even we see them diagnosis, but we need to monitor because the eye exam can change and lesions can grow and things can come up. I think what's really important to remember is a couple things about children. The first is children don't always tell us that they're having eye problems or vision problems. They just aren't aware of it, especially because we have two eyes. So when one's working well, we're not really aware that we have another one that's not working well, right? Because you see as good as your best eye. So we have to look, we have to examine. Regular exams are so important because we cannot count on patients telling us that the vision is affected. So we need to look and we need to do all of our testing to really evaluate thoroughly. The other thing that's unique about children is that their visual system is developing. So their brains are learning how to see. And it's so important that we give good vision early on so that their brain will develop normally and learn how to see well. So this is also another reason why eye exams are so important, because we want to identify things early, because we can identify them early. We can work together to decide what the next plan is, right? Are we monitoring? Are we doing some sort of treatment intervention? But early is key. And that's why we all work together so closely to make sure that our patients are in our care and part of our team.
Wonderful, thank you. Dr. O, from your perspective, when does surgery become necessary and what factors do you consider?
So in NF, about 10 to 30% of patients develop scoliosis. A lot of the scoliosis we do see tends to happen when patients are younger. And there's two types of scoliosis that occur in neurofibromatosis. One is kind of the more the gentler curves that we can see. They look very similar to the scoliosis seen in idiopathic patients. And these are patients who are very healthy. They don't have any underlying genetic conditions. The regular teenagers that you may see on the basketball team or the softball team, and they just happen to have scoliosis. So when NF patients have that type of curve, typically we will try to do everything in our power to avoid doing surgery because, while obviously it's my job to be a surgeon, it's asking a lot for our kids to kind of embark that journey with us in order to fix their scoliosis. So that may involve things like physical therapy. It can involve bracing. When curves start to get around 50 degrees, though, we know from natural history studies that the natural history of a 50-degree curve is one of progression. And that's going to be the case regardless of the patient, of whether the child has actually completed their skeletal growth. Right. So in those situations, we do recommend surgery. The other type of scoliosis that we can see in neurofibromatosis specifically is dystrophic scoliosis. And there's some features that we can visualize on an X-ray, which I won't go into too much detail, but these are curves that are much more aggressive. Okay, so they tend to be a much more sharply angulated, tend to remodel not only the spine itself, but the ribs. You may see outpouchings of the spinal fluid within the spine. And these curves are very aggressive, and we do recommend intervening earlier because these are the types of curves that become 100 degrees, 120 degrees. And when the curve reaches that point, we do get concerned about physical injury to the spinal cord itself, right? So typically we'll try to intervene on those curves as soon as we can. Now, that's often easier said than done because we also know that when we operate on children who are younger than 10 years old, and we do a standard scoliosis operation, which is the fusion surgery, and that's a surgery where we put in screws and rods at each of the affected levels of the spine and physically derotate the spine into a more neutral alignment. That affects how children develop, right? And so you're caught between a rock and a hard place because you want to address the scoliosis, but on the other hand, you want to give the child as much of an opportunity to grow, as much of an opportunity for their lungs to develop and mature as you possibly can, right? So what I would say is it's not a hard set rule, but if a child is under 10 years old, I try to do what's called growth-friendly instrumentation. And there's many different types of growth-friendly instrumentations that we can use. And the specific type we choose depends on the morphology of the curve itself. But these are, the downside to these surgeries are that they require multiple planned reoperations, right? Because the child is growing. These are meant to be a temporary solution to help guide the spine into a better position so that when the child is older enough, we can do a definitive surgery, which is the fusion procedure. So really at the end of the day, what it comes down to is that really the type of the curve that the patient has, whether it's dystrophic versus more kind of like an idiopathic curve, the size of the curve, again, using that 50 degrees as the threshold, and last, but probably most importantly, the age of the patient.
Thank you. So to all clinicians, NF care often involves many specialists. how can parents best coordinate communication between providers? Is there typically a lead doctor?
I think there are a variety of ways care coordination is done, right? And the model that we follow, and I think we cross the division lines often, very collegial. There are programs where there'll be a set care coordinator who would probably send out an email or message, or there are multidisciplinary clinic where all the subspecialists will see patients the same day. In my opinion, multidisciplinary clinics do not work really well for many reasons because on a particular day, my patient may not need Dr. O, or they may not need Neurosurgeon, Dr. O again, or another subspecialist. And it also creates a significant amount of anxiety and in the time that takes for a visit could be in several hours. So the model that we have, there is an assigned person who is quote unquote sort of a care coordinator who helps with scheduling and getting the messages across. But when it comes to patient specific questions, we pick up a phone and we speak, or we talk about our patients who needs Dr. Yeager, for example, ASAP, or if they need Dr. O. So I am sort of that person who would reach out after I see a patient and whatever their needs are. For example, if there's a plexiform neurofibroma, a patient is interested in getting surgically removed, I will reach out to our peripheral nerve sheath tumor surgeon. And also we review these cases, on monthly basis and sometimes on weekly basis at our pediatric neuro-oncology tumor board to discuss as a team what the care plan should be, where we talk about our patients, review their images. So that's sort of the model that we follow for care coordination, where we put the patients in the center. We talk about them, discuss them as a team, and come up with a comprehensive plan, more like after a multidisciplinary tumor board, as opposed to, having just one person who may be great and highly trained. But I think just assigning a care coordinator, in my opinion, sometimes does not do the job well. And others can weigh in. Dr. O and I, and Dr. Yeager and I, and others, I think we talk to each other about our patients quite often.
I would agree with that. We have a very hands-on approach.
Yeah.
So we try not to delegate patient care responsibilities, although there's certainly advantages to doing so. Dr. Kaur and I will call each other, I think, at least once a day, to follow up on patients, discuss their plans, and create a kind of an action plan for that specific patient. So we do communicate frequently, we communicate often, and we do it directly, right? So we know that there's no lapses of communication because we're the ones seeing the patients in clinic, and I try to communicate right after seeing the patient so that nothing gets lost in translation.